Good afternoon, everyone. Welcome and thanks for joining us today. We'll get started in just a few minutes. In the meantime, please be sure to take a look at this housekeeping side for a few notes, and you can feel free to introduce yourselves in the chat. When you're using the chat, just be sure to select everyone from that dropdown. Sometimes it defaults to just host or just presenter, so just be sure to select everyone when you are typing in that chat. Thanks. Good afternoon, everyone. Thanks for joining us today. We're just going to give it just another minute. Looks like we still have folks jumping on. In the meantime, please be sure to take a look at this slide here for a few housekeeping items related to CME CEU credits and certificates, as well as utilizing the chat function. Feel free to introduce yourselves in the chat. I mentioned just please be sure to select everyone from the drop-down menu. Sometimes it defaults to just one person or just the host. So we will get started in just a minute or two. All right, we are going to go ahead and get started. Welcome everyone who's with us today. Today we're going to have a special BHIPP resilience break focused on prescribing anti-typical antipsychotics in pediatric primary care. So this is going to be a special co-presentation by Dr. Shauna Reinblatt and Dr. Yen Dang. I mentioned, just in case you missed it, please take a minute to check out this housekeeping slide You'll notice that cameras and mics are disabled, so we will be using the chat function for any questions, any IT support throughout the session. There will be 15 minutes at the end for Q&A, and I will help facilitate that. So during that time, I will take your questions from the chat and have our presenters address those. If you're participating today to receive continuing education credit, you do just need to be on for 45 minutes or more in order to receive your certificate. And you do have to complete the evaluation survey afterwards as well. You'll see the link for that evaluation go into the chat, so please keep an eye out for that. It'll also be sent out through email after the session, in addition to the slides from today. And then also the slides and a recording of this session will be posted on our website. So you can also go back and look at those there. So now I'm going to go ahead and introduce our presenters for today. So Dr. Yen Dang is an associate professor of pharmacy practice and administration. She earned her doctorate of pharmacy from the University of the Sciences in Philadelphia and completed a specialized residency in ambulatory care at Temple University School of Pharmacy. Her practice site is located at Chesapeake Healthcare in Princess Anne and Pocomoke, Maryland. Dr. Dang is a member of the Maryland Pharmacists Association and Maryland Public Health Association. She's also certified as an immunization provider and sits on the statewide advisory commission on immunization. She serves as the director of global health at the School of Pharmacy, and she was selected as one of Maryland's top 100 women in 2019. Okay, and then Shauna Reinblatt is a clinical assistant professor at the University of Maryland School of Medicine, Department of Psychiatry, Division of Child and Adolescent Psychiatry. Dr. Reinblatt is board certified in general, adult, child, and adolescent, and consultation liaison psychiatry. Prior to her becoming a psychiatrist, Dr. Reinblatt worked as a family doctor in Canada. She subsequently completed a general psychiatry residency at Northwell/Hillside Hospital and a child and adolescent psychiatry fellowship at NYU School of Medicine. She then pursued a research fellowship in pediatric psychopharmacology at the Johns Hopkins University School of Medicine. So thank you, Dr. Reinblatt, and thank you, Dr. Dang, for presenting for us today. We're going to go ahead and take down this slide, and I will pass the floor to you both.
So can everyone hear me okay and see my screen?
Yes, perfect.
Okay, perfect. Well, thank you everyone for having me. It's a pleasure. And today we wanted to divide up this presentation for prescribing atypical antipsychotics in pediatric primary care into two components. For me, I'm a pharmacist by training. With a specialty in mental health. So I was going to describe and contrast the atypical antipsychotics used in pediatrics. And Dr. Reinblatt was going to describe the mechanism of action for atypicals, the best management practices for monitoring and atypicals in pediatric patients, and identifying clinical indications for the use of atypical antipsychotics in pediatrics. So we'll use the majority of this presentation for the atypicals or the second generation antipsychotics just because there's so many of them. And keep in mind that this presentation was not meant to be comprehensive of all of the antipsychotics. But as far as the atypicals, this is your main selection of the generics and brand names for the atypical antipsychotics to date. And the way they typically work is that they block both serotonin and dopamine at the receptor. Now, for the second generation antipsychotics, they block more of serotonin than dopamine, but because they have variable effects on dopamine and serotonin, that explains a little bit about the differences in side effects. And as a general idea of the side effects as a class, typically your second generation atypicals have a higher rate of metabolic disturbances. So most of them will cause things like weight gain, diabetes, dyslipidemia. Again, there's differences among the second generations. Also, compared to your older first generations, they have less incidence of things like extrapyramidal symptoms and tardive dyskinesias. These are movement disorders. And because they don't block dopamine, they don't raise prolactin levels typically as a group. And because there's differences among the different antipsychotics for your second generations, failure of one atypical does not mean failure of the class. So we can kind of subdivide your atypicals into three main sections. First are the atypicals that end with dones. Next are the atypicals that end in peens. And finally, there's three atypicals that I like to call two pips and a rip that are your partial agonists. So we'll start with your partial agonists, your two pips and a rip. The first one being aripiprazole. So this is a partial agonist, and there's a lot of different formulations, particularly oral dissolving tablets. These are typically given for patients who have swallowing difficulties and they have a faster onset, and it's available as an injectable. As far as clinical pearls, this is not meant to be exhaustive, but they typically have less metabolic effects compared to your other atypicals. However, this is balanced with more akathisia, which is your propensity to move. Another agent is brexpiprazole. This is the new and improved Abilify you can think of. The difference between this and aripiprazole is that it has a very long half-life. Similarly, the mechanisms and side effects are very similar. It doesn't have a lot of metabolic disturbances. This is also used in major depressive disorder. It has an FDA labeling for that, so there is a black box warning for suicidal thoughts and ideations, particularly among the young patients. We also have cariprazine. This is the last partial agonist of the class. And similarly, it has very low incidence of metabolic disturbances. And here, the only difference is that it could cause a little bit of cataracts. So they want you to monitor eye exam, particularly in the older population. So among your next atypicals, these are the ones that end in peens you can think of versus acenapine. This is available as a sublingual tablet typically. And aside from the fact that it doesn't cause a lot of metabolic disturbances, it does cause QT prolongation. So you have to monitor the EKG. And for the sublingual form, it's important not to eat or drink 10 minutes before taking this because it's going to decrease the bioavailability. You also have to monitor for allergic reactions, particularly anaphylaxis when taking this. We have quetiapine. Here, the way I remember quetiapine, it has the word quiet in it. So it is a little bit more sedating than the others. It's sometimes used off-label for insomnia. And as far as the side effect profile, I would consider this somewhere in the middle. So aside from the sedation, you also have things like moderate metabolic disturbances and also cataracts. With quetiapine, though, in terms of EPS and other movement disorders, this has less compared to the others that we mentioned, only second behind clozapine. We also have olanzapine. This is available in different formulations. So we have an injection, long-acting injections, oral dissolving tablets. And here it's notorious for causing metabolic disturbances. So weight gain, I've seen patients gain 30 to 50 pounds on olanzapine. Not necessarily a bad thing if they have a very low BMI. But typically in terms of anticholinergic effects and metabolic syndrome, olanzapine is pretty much the second to worst antipsychotic out there. But of course, the one that has the most side effect is clozapine. So clozapine is the most effective antipsychotic out of all the second generations, and as a result, it's used for treatment-resistant schizophrenia. But we don't like to use this first line because it causes all the side effects. So very, very high metabolic disturbances, very high anticholinergic effects. It causes hypersalivation. So some patients have to sleep with a pillow underneath or a towel underneath their bed. It also causes pro-inflammatory cytokines. So some patients might get myocarditis and cardiomyopathy. But on the other side, it doesn't cause any movement disorders, particularly tardive dyskinesia, which before was typically irreversible. And for clozapine, you can monitor for efficacy, so we get a concentration of greater than 350. It also causes seizures, which is dose dependent, and something called agranulocytosis. So here it's only dispensed for people who are registered in the clozapine registry. And you typically have to monitor things like your white blood cell count, ANC, before you administer clozapine with every dispense. And here, I'm not going to go through this, but typically the incidence of clozapine-related agranulocytosis, it's typically time dependent, not dose dependent. So we monitor ANC and white blood cell count a little bit more frequently in the beginning. And if any point your blood cell count drops, then these are kind of the parameters of how you would hold it or how often you would test and re-challenge it. And finally, we have ziprasidone. This one has pretty much minimal metabolic disturbances, but the downside for this is that it causes severe QT prolongation. So if your patient already has any arrhythmias, if they have a recent heart attack or MI, if they're older, if there are any drug interactions that prolong the QT interval, this really should not be used. Also, it has to be taken with food to increase absorption. If you take it on an empty stomach, absorption decreases about 50%. And also, this has been associated with a lot of akathisia, which is your propensity to move. We also have risperidone. The main thing that I think of is that it causes hyperprolactinemia. So it could cause things like gynecomastia, which is the enlargement of breasts, as well as sexual dysfunction. These are side effects that are typically dose dependent. So we try not to use doses greater than 6 milligrams. And as far as metabolic disturbances, this is somewhere in the middle. And the cousin drug to risperidone is paliperidone. Here, it causes pretty much the same side effect. The only difference between this and risperidone is that the tablet is eliminated in the stool, as well as it could cause QT prolongation. One of the newer drugs that we have is iloperidone. In terms of side effects, it's somewhere in the middle. Also causes QT prolongation, similar to ziprasidone. And finally, we have lurasidone. So here with lurasidone, it has pretty much neutral side effects for the majority of these symptoms. However, you have to take this with food, particularly 350 calories, because again, the absorption will decrease. And finally, we use this a lot in things like bipolar depression. So there is a black box warning for suicidal thoughts and ideations. So that was all the atypicals out there. Again, I know that there's a lot of atypicals, and usually atypicals right now are typically used over your typicals or your first generation antipsychotics. I'll briefly talk about the typicals, but we typically don't use this very much anymore because they have a lot of side effects. The things in bolded are the ones that we typically more so use, but because they differ in chemical structure, they also differ in side effects. So failure of one typical does not mean failure of the class. And the way the first generations work is that they block dopamine at the receptor. They don't affect serotonin like your atypicals. And they also affect your alpha-1 receptor, they block histamine, and they cause anticholinergic side effects. So again, because your first generation drugs have more side effects, that's the main reason why we typically don't use it. And as far as dose equivalencies, this is FYI, but most of the time we compare the different typical agents with chlorpromazine being your first prototypical type. And you can kind of stratify your typical agents based on potency. So for high potency, Haldol and fluphenazine being your prototypical drugs, this typically has a higher risk of movement disorders, but at the same time, it has a lower risk of orthostatic hypotension, tachycardia, and anticholinergic side effects. Versus your lower potency drugs like chlorpromazine and thioridazines, it causes the opposite. So low risk of movement disorders, but higher risk of things like sedation, hypotension, and anticholinergic side effects. Typically, though, in practice, we use Haldol, the most common out of all your typicals, particularly in the emergency setting, because compared to the others, it has more tolerability. And finally, as a class for the typicals, the main reason why we don't use it at all that much anymore is the side effects, particularly your movement disorders. So as a class, it's notorious for causing extrapyramidal symptoms, also neuromalignant syndrome, which could be a life-threatening disorder. It causes a lot of side effects for your anticholinergic side effects, sedation. It causes hyperprolactinemia, which could cause sexual dysfunction. And a lot of it is dose-related for QT prolongation. So as far as the treatment algorithm, typically you start with either a first or a second generation for stage 1 and 2. But again, because nowadays second generations typically have less side effects, typically second generation antipsychotics are preferred over your first generations. If you fail 2 trials, you move on to clozapine, which is your most effective antipsychotic out there. And if for any reason you fail clozapine, you can go to your augmentation strategies where you combine clozapine with a mood stabilizer or an antidepressant, or a combination strategy where you can combine clozapine with another antipsychotic. But typically stage 4, there's less evidence for this. And finally, for treatment considerations, when choosing an antipsychotic, typically, again, second generations are more preferred, but you consider things like patient preferences. So some medications are dosed once versus twice a day. Some are available as long-acting. Past responses to treatment, if they worked before in the past, what the side effect profile is, and if the patient has any health conditions, things like cataracts or diabetes or hyperlipidemia. You also look at drug interactions. Typically, these drugs affect things like their CYP enzymes 3A4 or 1A2. So when giving antipsychotics, it's always important to perform a drug interaction check. And with that, I will turn things over to Dr. Reinblart to consider your clinical considerations.
Thank you very much, Dr. Dang. That was a very interesting talk, and I love your first slide. Let me see. I gotta share my window. Hopefully you can see this. Okay. All right. So I'm going to talk about the clinical considerations, as was just mentioned, and apply. I'm only going to focus on a few of those many atypical antipsychotics, because I think in kids we mainly focus on a few of them. So, and really, offer some clinical tips and review some basic stuff as well. So here is the case. So here's a 10-year-old boy with ADHD who's on the spectrum, high functioning, with really no past medical history, pretty average BMI, not overweight, but started being aggressive at school and at home. Not new behaviors, but sort of increased acute on chronic. Has services at school, but having difficulties, again, both at school and at home. Irritable, kind of constantly irritable, aggressive, obsessional thinking, rigid, and has difficulty with transition. So pretty typical kind of case. No clear auditory or visual hallucinations, but seems to think his video games are real. And, when he's alone, he sort of talks to the video game characters. So maybe some reality testing issues, but no imminent sort of safety concerns, no suicidality, homicidality. And the aggression is usually in the context of being redirected from playing with his computer or doing activities that he's very motivated to do. In terms of other psychiatric medications, so for the ADHD, he takes guanfacine, ER Intuniv 4 milligrams at night, and Vyvanse 40 milligrams daily for ADHD, which had until about 6 months ago worked very nicely to control his hyperactivity and inattention, and as well as maybe helped with the aggression, because this seems to have been a more recent increase in his aggressive behaviors. So anyway, he's had multiple prior ADHD trials prior to that, since he was quite young, and really doesn't have any, problems with his ADHD meds. He's adherent, and they've tried lots of different things. And he does get, through his IEP, some behavioral services. He gets therapy at school. But mom had come in and dad to talk about like other options in terms of the aggression and what else could be thought of, and are asking you about antipsychotics. So I thought I would start off with that. And let's go through some prescribing principles we can think about as they come into your office. And, the wait list is typically so long to get into child psychiatry. And you may or may not be calling BHIPP, but let's review the kind of concerns you might have as you're talking to the parents and thinking about this in the context of that case or any other case. So I described a few kind of prescribing principles or tips that I think about. So the first thing is that even if you don't have a firm diagnosis, to have an idea in your head of kind of what you're targeting in terms of a working diagnosis, let's say, that really helps you kind of figure out what to prescribe, especially in primary care. I mean, having, as Chelsea said, been a family practice doc previously, I know how busy it can get, and it's really hard to like sit there. You just don't have the time to do a full, in the context of a visit for other things, it's hard to touch everything. But just having an idea. So like with the prior case, we were talking about a kid on the autism spectrum with irritability and aggression. So you kind of have your working diagnosis and your targets sometimes, at least, foremost in what you're thinking about. And then, so we have, the diagnosis, a couple of target symptoms, like what are you aiming? What are you kind of thinking you're going to help with? And basically, these are meant as guidelines, obviously, every case is different. But generally, if you don't have an idea about what you're using it for, what the indication is, and it's just like aggression, then that wouldn't necessarily be a reason to prescribe an antipsychotic. And we'll talk about level of care in a minute. So, and another really important one is kind of what was tried before. So if the kid's being super hyper and impulsive and aggressive, and you think there might be ADHD, particularly in the younger kids, you might want to explore that because, in kids, as we all know, a lot of stuff is comorbid. And so what has been tried before, and I didn't put it here, but, psychotropic meds are really important, but also like, has the child been in therapy? And also what meds is the child on now? And so the case we just discussed, this kid is on, an alpha agonist, the Intuniv, and a stimulant. So the ADHD had been controlled and had many prior trials for ADHD, and although I didn't put it in the case, any other comorbidity had been ruled out using some screeners and by history. So I thought it might be helpful to just briefly touch on, things that aren't typical indications. Now that's not to say that some of these can't be, used as targets, but in general, insomnia is not something in kids that we use an antipsychotic for. So Seroquel for insomnia, for example, I hear a lot about that. There are other things before even considering that. And so in children, because there is less data, we tend to do things a little bit differently than for adults and, try to follow the practice parameters more. So that would be one reason. When you have developmental delays or learning disabilities, you often are, treating the child with in conjunction with someone else, or you have, again, a mental health diagnosis or target symptoms. So you're not directly treating any kind of developmental issues or language communication problems. Adjustment disorders, if the child looks like depressed or anxious or had a trauma. I mean, usually when it's an adjustment disorder, it's time limited and you would be thinking of other treatment options. ADHD alone. So this one I hear a lot, like ADHD, they're so hyper. Or they're really impulsive and they're doing kind of dangerous stuff. So it's important to, in general, and not every case is the same, but to try to optimize the ADHD treatment and make sure that they've been tried on something before. Anxiety disorders, back in the 1950s, and Dr. Dan can talk to this much better than I can, but, initially in the 50s, when they had the typical antipsychotics, they used to, in adults, give it for anxiety. We don't do that for kids, and we don't typically do that even in adults anymore. But also, if there were, migraine headaches, stuff like that, none of those kind of somatic complaints. And also in very young children, particularly if there have not been other treatment trials. So really young kids, sometimes it gets tricky with the kids on the spectrum, the autism spectrum, but generally I'm talking about like 2-3 years old. It gets kind of like, those are not like first line by any stretch. Okay. And then what I was talking about before is, you have this kid who comes in and they're aggressive. I didn't go into detail in my fictional case, but, there's no acute concerns. The parents can still control the child at home. And at school, he's not being suspended, but he's certainly at risk for suspension from school. And there wasn't a risk for placement. The parents felt comfortable, even though they weren't happy with the situation, but there wasn't like an imminent danger at home. And he wasn't, kind of, trying to hurt himself, and he wasn't aiming the stuff he was throwing at his parents, but, it was escalating. And so I just wanted to kind of remind everyone that as we're treating the kids and, they might come in and have this acute sort of aggressive outburst, which can be really scary, or maybe they're aggressive in the office, or, think about using crisis services and higher levels of care if you're really concerned about the patient. And I think with that, it's your gut feeling. You'll know a lot of times when you just don't feel comfortable sending them home. Sometimes I'll talk to the parents like, I don't know, I'm not going to sleep tonight. I really think, we don't have time to go into this. And sort of, if there's a crisis service nearby who can do an evaluation, sometimes that's a good option. And we've talked about that sometimes on cases on the phone through BHIPP on clinical consultation. So just, assessing safety is always important. So I'm sure I don't have to go into that in detail with this group, but I just wanted to mention it. Okay, so number 2, we want to follow evidence-based, standards and practice and standards of care. Unfortunately, with children, there's growing data, but it's not all, it often lags behind the great data we have for adults, right? So what kind of evidence base am I referring to? So we don't have time to go into it, obviously, but, we look at pediatric studies, certainly, the younger the age, less studies, adult studies, although they aren't always directly applicable. Sometimes it can help guide things. Examples for that would be sort of long-acting injectables. We have, mostly adult studies and not a lot of data for kids. There's now mounting studies starting, but So sometimes we have to look at the adult studies for stuff to help guide us. FDA sometimes puts out, SAMHSA has a antipsychotic kind of recommendations that you can link through on the AAP site. Other expert consensus guidelines, so the ACAP one is the one that I'm going to refer to in this, and I can send around the link if anybody wants it, but it's available free online from the American Association of Child and Adolescent Psychiatry, the American Psychiatric Association, and other clinical kind of guidelines. And of course, expert consultation. Whenever there's a question about things, I often will go to colleagues or get a psychopharm consult. I also work on a prior auth consultation service. And, oftentimes I will consult my, child psychiatry colleagues and specialist pharmacists who really sometimes we can have, find a, talk about cases and think it through because sometimes they're really complex. So in terms of, approved antipsychotics, and again, these are just like second generation, or some people talk about like third generation for Abilify, but I'm not going to go into that. It's beyond the scope of this talk. But for kids, there's a lovely table in Dr. Riddle's book that some of you have, the Pediatric Psychopharmacology for Primary Care. But this is just kind of a very simple slide. So there's 3 main indications in pediatrics. So there's autism, and just due to the scale that they use, they looked at irritability due to autism, but often that overlaps with aggression, as we know. So irritability due to autism, we know from age 5 and up for Risperdal and Abilify, or our Aripiprazole, it's age 6 and up. And then there's schizophrenia is mainly from early teens, 12 or 13 for risperidone, Abilify, Zyprexa, Seroquel, Invega, and Latuda. And then for bipolar, as Dr. Deng had mentioned, Latuda's the indications for bipolar depressed, age 10 and up. And then depending what you're looking at, they're mostly 10 and up for bipolar. For Risperdal, Abilify, Zyprexa. Zyprexa is actually 13. I always forget them. And Saffris and Latuda. So, one can see, and I think it's really great we can compare and contrast it to Dr. Dang's talk on, the mechanisms and the non-clinical aspects, because you can see that the list for kids is shorter, right? So it gives us an idea. And again, if you look at the ages, you can see why we all try not to give it to the younger the kid, the more complicated the decision making is in conjunction with the parents. And mainly, autism has the youngest indication, as you can see. And really what you want to try to do is just avoid outlier prescribing. And by that, I mean just using like atypical doses, super high, not having sort of, like we talked about, other kind of treatments. And if it's a refractory illness, to kind of look back, recheck your diagnosis, recheck the meds, do all the stuff that we typically will do. And in terms of doses, we don't have time to go through all of them, but this was, typical start doses. And there's, again, a really nice chart in Dr. Riddle's book, published by the AAP, with kind of target and max doses also. But this gives you an idea. We really do start low, and that start low, go slow really is the way I tend to approach these cases, and starting like really super low and then going up slowly. And when you have to switch, if you ever have to switch them, then also sort of tapering. Anyway, so this looks at the main antipsychotics. It's just a brief summary slide. So like for Abilify, it would be like 2 or 2.5 milligrams for the typical kid. If you had someone who weighed more, certainly you could think about a 5. But And there's other guidelines like Texas guidelines you can look at and stuff like that, but this is just sort of a conservative approach. So here we have just a reminder about psychosocial therapy. I didn't go into great detail here due to time constraints, but there are studies mainly looking at Medicaid patients who are on antipsychotic medications like pediatric patients, and looking at, it's pretty astounding to me that there's a great percentage who have not been on psychosocial treatment and are started on antipsychotic medications. And in general, most of the guidelines do recommend psychosocial treatment in conjunction with antipsychotic use. And it's particularly with the younger patients, but in general, if the illness is severe enough to require an antipsychotic medication, typically there are issues happening or other comorbid diagnoses, or even the diagnosis you're targeting, that the child would benefit from a psychosocial approach. And this, I'm not focusing on any one typical one here, because the studies have looked at different types and it's beyond our scope today. Okay, so now monitoring and side effects. So weight gain, I mean, we all know about the risk of weight gain with, today I'm talking about atypical antipsychotics in this talk. And so that's, I think the number one thing we tend to see when they come in for follow-up visits. And, active counseling on healthy lifestyle, behavioral changes, sometimes getting nutrition involved and doing that referral. Youth are certainly more vulnerable to the side effect, but obviously, as you heard from Dr. Dang, everybody is at risk. And we'll talk about the sort of lab monitoring in a minute, but sometimes, and depending again on which specific atypical you're using, as Dr. Dang mentioned, you can see a great increase in baseline weight, but with kids, you often do see it in those first few months, but it can continue. And particularly with the olanzapine as in adults. I didn't mention clozapine here because I'm focusing more on sort of the primary care orientation, but certainly clozapine would be up there as well. And then quetiapine. But these are just general guidelines. And of course, every child is different. Probably Abilify and Latuda probably have the least propensity. And I'd put ziprasidone there as well, which I didn't on this slide, but it would be on the lower end of kind of risk. And then just to quote again, I'm a little biased being a child psychiatrist, for ACAP being a child psychiatry practice parameter, but they actually did look at antipsychotic medications. Now they don't give specific, like, you should do it this amount. And, all these guidelines are generally just, tips and suggestions by people who are really experienced in this area. The one thing I did want to just quote is that, they do suggest as their third recommendation to obtain a personal, and I'm sorry about the typo, family history of diabetes and hyperlipidemia, seizures, and cardiac abnormalities, due to the risk with antipsychotics of all of those and lowering the seizure threshold, and also of a family history of any kind of response or adverse effects with antipsychotics. So, the nice thing in primary care is your patient, so you would be best placed actually to know these things and evaluate that. So I really think that that places you in a very good position actually to know, to get that history and have it readily available. In terms of, we know that in terms of dyslipidemia, there's some studies looked at it and it's pretty consistent, just like for adults. And again, olanzapine, quetiapine seem to have a rather big increase. And I focused on the lipids, but the LDL can go up, and certainly, as we'll talk about in a minute, a fasting lipid panel will help monitor for that as part of the metabolic syndrome. Olanzapine, interestingly, apparently has a direct hepatic effect and can increase fatty liver in kids, although there's a risk with all the antipsychotics. But and the risk, sort of my general picture, and of course this is not exact in any sense, But just to give you an idea, it's pretty much the propensity for metabolic syndrome is pretty much, I think of it similar to the risk for weight gain. Like your olanzapine is going to have the highest risk. Quetiapine's pretty much up there. And then your Abilify Latuda is probably on the lower end. That doesn't mean that it's not going to do it. And that doesn't mean that some kids won't gain a ton of weight on Abilify Latuda and ziprasidone, but your risk is lower. And so monitoring the weight, the BMI, they also talk about measuring the waist. It's hard in kids though, especially if you have the kids that you're treating with these medications, oftentimes you're lucky if you get a height. So getting a waist measurement is often not, and lab monitoring can be pretty challenging also. In the interest of time, I'm not going to go over this much, but basically, the risk of diabetes and, type 2 diabetes can be, obviously your risk is increased compared to healthy controls about twice. And then other specific side effects, I like to think of them as, the extrapyramidal or, Parkinsonism. So I'm just briefly going to do a refresher. I know you guys know this, but, dystonia, the cogwheeling or Parkinsonism, that goes along with the drooling and the rigidity, cogwheel rigidity, shuffling gait or decreased arm swing. You can see all those things, although in kids, it's usually sort of more feeling stiff muscles, cogwheeling, because they're so, resilient. But you can see, particularly in the teenagers, the drooling and acute reactions. Akathisia, or that feeling of internal restlessness. Sometimes you'll hear, like new ADHD symptoms, sometimes as a tip off, and then tardive dyskinesia. So just briefly, dystonia. So the thing I always worry about, and one of the reasons we always talk about in kids, like in particular, starting at a low dose, is because if you do get a dystonic reaction and you happen to get a respiratory or a laryngeal dystonia, it can be not only scary, but extremely dangerous. And yes, most of the time it's treatable, but if you have, if you start on a higher dose, they may then have more of a chance of getting the dystonia, particularly if they're in a risk group, like, young boys, for example. And it can be really dangerous and scary. So starting at a lower dose is also important for that reason. And I really can't highlight that enough, because some people will think, I've been asked, well, why does it really matter? So they'll sleep more. And I'm like, yeah, they might sleep more with a higher dose of an antipsychotic when you start it, but they have this risk of dystonia. And this respiratory or laryngeal dystonia, which is summarized on the slide actually, can be really dangerous. So any dystonia can be treated with, Benadryl or benztropine, but it's not something you want to see in your patients. The respiratory version or any of the other ones, really, they're very painful. And so you can have, cervical dystonias, and you can have cramping, and you can have, spasms. Just move. You can have blepharospasms. And so your risk, every time you increase the dose, there's a risk. And every time you start at a higher dose, there's a risk. So I got this slide off the Michael J. Fox Parkinsonism site, but it nicely summarizes the symptoms you could have. Now, they're rare. I'm not saying this happens to a lot of kids, but if you prescribe in a way that's gradual, the risk is much lower. And again, with typical antipsychotics, not second generation atypicals, the risk is certainly higher. Okay, now why isn't it moving now? Sorry. And it stopped sharing. Okay. We talked about sort of resting tremors, cogwheeling, sore muscles. Sometimes I'll ask the family. You guys know this stuff. Akathisia. So this one can be really tricky. So it's that feeling, like sometimes I'll say, If the kid's old enough, you can ask if they feel like inside, like they just can't sit still, like it's almost like a motor running inside them, like they just can't sit still, or they're jumping up and down and they never did that before, especially. And it gets tricky when they have ADHD too. But new onset fidgetiness with an increase of an antipsychotic can be a tip off. Or, and this is like a big take home for me, if I can impart anything upon you, when you raise an antipsychotic med and they get worse, the symptoms get worse, always think about akathisia, that maybe there's a iatrogenic worsening from the medication. So you're worsening their symptoms. So sometimes they can get the restlessness and the symptoms get worse as you're raising the dose. So anytime you raise the dose and they're getting progressively, which each step worse, find out if they're old enough, you can ask them about the internal restlessness. And if not, you can try to get a history or just try to lower the dose. Tardive dyskinesia, Dr. Dang already talked about this. Basically, you're talking about lip smacking and abnormal movements. Generally, they can appear as you lower the medication. Sometimes it can be masked. Oftentimes it's in kids who are on the meds for 6 months, a year. They're usually on it for a while. Any of these movement disorders I didn't mention, but I don't have to talk about it much with this group, I'm sure, but just make sure there's nothing neurological going on, because there are underlying neurological issues that can cause this, even in a kid you put an antipsychotic on, but also there can be underlying etiology. So anything, I'll show you a very brief video in a sec, if I can get it to move. Okay, and this is the abnormal involuntary movement scale, which looks, it's a horribly busy slide, but basically, looking at rating kind of any kind of involuntary movements. It's used in children, and it gives us an idea of whether there's something emerging and how to follow it. The issue is sometimes, like, they talk about tongue movements. A lot of kids who are like ADHD might have sort of developmental, it's just delayed development, basically. So they might have a slight tremor, and sometimes it gets tricky to tell the difference. So this is just, I won't play the whole thing, but this is a sample. Well, maybe it won't play. It won't play. That's the end of that. So this is supposed to show you him doing an AIMS, but for some reason it does not appear to be working. Okay, well, I guess we don't have that much time anyway, so let's move on. Basically, you watch the patient walk and you see how they swing their hands. You stick out the tongue, you check for tongue fasciculations, watch their general facial demeanor, have them, touch each finger as they're sticking out their tongue to watch for it. So you don't have to do a lot of that, but, doing a cogwheel and observing the patient, I think, is the take home. And if you can do most of the AIM scale, which some of the prior authorization programs will request. So I just wanted to kind of highlight that. Okay, and then there's a small risk, but it's there, as Dr. Dang talked about, neuroleptic malignant syndrome. That's life-threatening. That's usually as you raise the dose really quick, and it's a high doses in general. You see rigidity and CK elevations, changes in mental status. They seem delirious, and you get an autonomic instability. So your vital signs go, temperature and all the rest. You can get them high, low, and everything in between. So anyone who gets like super delirious all of a sudden on an antipsychotic, just keep this in mind. Okay, and all right, and QTC prolongation, they divide out between males and females. The the cutoffs, the males are lower and at 450 for boys. And it changes. I'm obviously not going to go into it with this group. If you're primary care, all about EKGs and QTC. But the risk, of course, is higher with ziprasidone. There are other ones that are high as well, but making sure, as Dr. Dang mentioned, like, what other meds are they on? Are they on like clarithromycin, which also can prolong QTC? Sometimes that's a big thing. Like That's contraindicated together. So just keeping that in mind, particularly with some of the antibiotics, I would say, and also with other medications, Prozac can prolong it and stuff like that. So getting an EKG prior to starting the medication would be particularly important with someone you're about to start like Geodon with because of that risk. And then maybe a little, they still can prolong QTC Abilify, but it's lower. And so that's when kind of getting that history, the family history of, personal and family cardiac history, and seeing if there's risk factors and looking at the concomitant meds to see the risk. And then of course there's corrections that can affect like the length of your QTC. So we won't go into that a lot, but just to remember. And of course, torsade de pointe is what we're always worried about, and sudden cardiac death. Okay, and then so follow-up, we're running out of time, so I'm not going to go over this in detail. Dr. Dang had talked about the hyperlactin, galactorrhea. Sometimes you can see headaches. I'm trying to think what else we didn't talk about. Dry mouth, constipation, and certainly like sedation. Like if someone's going to school and they're too sleepy, like olanzapine sometimes and quetiapine are like super sedating. And for hyperlactin, like if they're on risperidone and they get, galactorrhea or, some, oftentimes there are those second generations that'll do it less, like Abilify, for example, as was mentioned. So every visit, it's important to talk about adherence because you want to keep in mind, you want to make sure that they're actually taking the med, because if they're not and you're represcribing it and it's not just like a start dose, then you could be exposing them to a higher than typical dose, and you really don't want to do that. So you really want to just check, not in an accusatory manner, and just to make sure so that everyone's on the same page. And if they're not taking the med, oftentimes you might need to restart it or at least discuss with them. It's not dangerous if they start it, if they weren't taking it, if they stopped it. However, if you restart it and they're at a super high dose, that's not something good, again, because of different risks, including what we already talked about, the risk of dystonia. Side effects, we talking about that, just to check in about that and about whether it's working. So always kind of going back to, is this working? Working together with whoever's doing the therapy as well. And following the BMI closely, the blood pressures, and then just getting to the issue of the lab work in general, and this can vary and the guidelines are a little different, but it's usually fasting glucose, fasting lipid panel, and LFTs, the liver function tests. They usually do it at baseline and then at 6 months and again at a year. And after a couple of years, if they happen to be within the normal range of the BMI, sometimes it's possible to think about prolonging for a year, like doing it yearly. But at first, certainly to do it every 6 months. Now, some kids, like especially those on the autism spectrum or who are super anxious, might not want to go for the lab work. And so there are other things you can do, like, obviously not optimal, but like dipping the urine to make sure they're not like spilling glucose, or, if it's a child with autism, sometimes they go for dental cleanings under anesthesia, and oftentimes you can arrange with whoever's doing that to take the blood tests that you need. And of course, this is all as clinically indicated as you feel as the clinician. And then as Dr. Dang talked about, polypharmacy issues. So we talked about clarithromycin and Geodon, and prolongation of QTC, optimizing doses before adding. So like it's always better to try to get the dose up a little bit as you slowly raise it and then add something, rather than having two very low doses together, because then you're exposing them to two antipsychotics. And stepwise adjustments, we talked about basically just reevaluating how the child's doing. And then if there's a non-response to just, you could certainly call BHIPP, or have other psychopharm consultation, and switching slowly. So when you want to take a child off an antipsychotic and start another one, it's often good to do it very slowly to do the switch. Dr. Dang already talked about, some medications you want to take with food, some not, some dissolve. And so thinking about what formulation you're going to use and not getting scared. Sometimes you might see just like with some ADHD meds, like there might be capsules in the feces. So I try to discuss that. And although we didn't talk about it at length, obviously having an informed consent discussion with the parents is important. All right, so that's basically it. Waiting long enough to see if there's a trial. And if there's any questions, please feel free to call BHIPP. So with that, I know we went into the time for questions. How do I take this off slide sharing? Stop.
Thank
Yeah.
you, Dr.
Okay.
Thank you, Dr. Dang. We still have about 2 minutes, so if folks have any questions, feel free to go ahead and place those in the chat at this time. I did see a question pop up while we were talking related to are we experiencing any shortage of medication similar to stimulant medications? I'm not sure if there was
Right now, there is a shortage of haloperidol injections that's hitting the hospital. That's pretty much the only antipsychotic that I'm aware of. But in the outpatient side, there is a big shortage right now of the Razapam tablets.
Thanks, Dr. Dang. Give folks a minute. If there's any other questions, go ahead and put those into the chat at this time. All right, I'm not seeing any questions, so I think we might be able to go ahead and wrap up. Thank you everyone for joining us today, and thank you Dr. Reinblatt and Dr. Dang again for a wonderful presentation today. I hope everyone has a wonderful rest of your day.